Perfect. All right, so thank you, everyone, for attending. Firstly, I'd like to ensure that everyone can hear me. So if you are able to, can you please type yes in the chat box? You'll find that on the left-hand side of your screen. Excellent, great. Just wanted to make sure. It appears you can all hear me, so that's wonderful. Welcome to Asthma Canada's Speaker Series webinar. Our 2019 webinar series has been made possible through educational grants from AstraZeneca and GSK. This is our third webinar in our 2019 series, and today we'll be speaking about vaccinations, particularly on influenza and pneumococcal disease. This is an increasingly important topic for Asthma Canada and our community, and I know many of you have been looking forward to this, so thank you for joining. My name is Jenna Reynolds, and I'm the Director of Programs and Services at Asthma Canada, and I'll be moderating today. I also wanted to acknowledge our partner, Immunize Canada, a national coalition of non-governmental, professional, health, government, and private sector organizations who focus on promoting the understanding and use of vaccines as recommended by NACI, the National Advisory Committee on Immunization. Thank you, Immunize Canada, for your contributions. Before we begin, I'd like to go over some quick housekeeping rules. Just to note, this webinar is being recorded and will be uploaded at a later date to our website. All attendees are muted, but at any point, if you have any questions, comments, or issues, please type them into the chat box, and I'll be monitoring that throughout. There's also a little blue question mark at the top of your screen. You can also feel free to type any questions you have there. There will be a Q&A at the end, but please make sure to type your questions in as we move along throughout the presentation. And very briefly, I'd like to highlight some of our work. Asthma Canada is the only national organization solely devoted to helping all Canadians affected by asthma. We're committed to improving the lives of the Canadian asthma community through education, support services, research, and advocacy. Our work focuses on the missing gaps within the healthcare system, mainly through providing education and support for patients and families, both in print and online. We also advocate to the Canadian government on improving health outcomes for people living with asthma. A current focus right now is on access to medicines, also known as national pharmacare, for fair, equitable, and universal coverage across the country. And of course, Asthma Canada supports research into better health outcomes and the eventual cure for asthma. We have a national research program which supports graduate-level students studying early or late adult onset asthma. Please visit asthma.ca for more information. And much of the work that we do is through our community of volunteers and members across the country, people living with asthma, their families, parents, caregivers, healthcare professionals, educators, and others who are strongly committed to providing and improving asthma care and quality of life. The Asthma Canada Member Alliance is a free membership of Canadians who engage in all of the work that we do and who provide support and input into all of our initiatives. I would welcome you to join us if you have not already. And lastly, we are excited to announce that we have launched a new survey yesterday with partners exploring vaccinations in the Canadian lung community. So if you are a resident of Canada who is over 18 and living with any lung condition or a healthcare provider practicing in Canada, we invite you to participate in our quick 5-minute survey. Your participation will help us understand the behaviors and attitudes towards immunization among adults with lung diseases in Canada and identify any barriers that may exist. In a moment, I'll add the links in the survey to the chat box so you can participate in that. And now I'd like to introduce our distinguished presenter, Dr. Alison McGeer. Dr. McGeer trained in internal medicine and infectious diseases at the University of Toronto. She then completed a fellowship in hospital epidemiology at Yale New Haven Hospital. She was a microbiologist and director of infection control for Sinai Health System from 1990 until 2019. She is currently a clinician scientist at the Lunenfeld Tannenbaum Research Institute of Sinai Health System and a professor in the Department of Laboratory Medicine and Pathobiology at the Dalai Lama School of Health at the University of Toronto. Her research interests in the prevention of healthcare, associated infection, and antimicrobial resistance and adult immunization. Dr. McGeer, it is my pleasure to have you with us, and thank you. And just to know for everyone here is that I will be advancing the slides under your direction. Thank you.
Thanks very much, Jenna. Okay, at least it was a little cooler this morning, so maybe we're ready for the fall to come and to think about influenza and pneumococcal vaccine. But I know I think it's become one of those bad markers of winter is coming and perhaps also a bad thing about influenza vaccination that we associate it with the end of summer in some way. However, here we go. Next slide. What I'm going to try to do in the next 35 or 40 minutes is first of all to talk about infection due to influenza and streptococcus pneumonia, or the pneumococcus. That's piece one. Part two is then to talk about some updates about vaccine recommendations for influenza and strep pneumo. And then finally to think about some reasons why people don't get vaccinated and what we can do about it. I'm conscious from the questions that got asked in the seminar that almost everybody who is registered is planning to get their flu vaccine. I think it's helpful to know why other people feel the way they do about vaccines and what we might be able to do about changing their mind. So, first of all, why do we care about influenza and pneumococcal disease? If you move to the next slide, you're looking at the top 10 causes of death in Canada, and influenza and pneumonia together are number 8, and you might look at that and say, geez, maybe that's not so important. But when you think as a physician, as a public health professional about what you can do to improve people's lives, things have to be important, but they also have to be doable. And that's why, even at number 8, because we have vaccines for influenza and pneumonia, using those vaccines is really important. Infectious diseases in Canada used to be the number 1 cause of death. Now, with vaccines, they're at number 3 or 4, and we'd still like to be even lower. If we actually really use vaccines that we have well, we can probably move ourselves even further down the list of causes of death. Okay, so let's talk about infection with influenza and the pneumococcus. This is a picture of a side view of somebody's nasal cavity going down to their lungs. Influenza infects you in the cells of your nose and the back of your throat. That's where the pneumococcus lives normally on the surface, not causing any damage. When the pneumococcus causes infections, because it gets into the lungs and then invades through the tissue and infects the lungs. So the next slide now is a picture of an influenza virus infecting a surface cell on the back of your nose and down into your upper airways. The virus binds to the cell by the hemagglutinin. It releases its contents into the cell, and remember that viruses don't have their own machinery for replicating. They use yours, so they co-opt the cell, they make a whole lot of new viral particles, and then those viral particles go to the surface of the cell and are released where they can go and infect more cells. When that happens, the cell on the surface dies, and that's why you get symptoms from influenza, because the influenza kills the surface layer on the back of your nose and throat. And if you look at the next slide, then you get a stuffy, runny nose because of the inflammation. Your throat gets sore. And then when the viral concentration gets high enough, it triggers an immune response so that your body moves in to get rid of the virus. And when that happens, you release small molecules called cytokines, which give you muscle pains and headache and feeling unwell and fever. And so it's that combination of irritation of your upper airways and the release of cytokines to make you feel miserable that gives us what we think of as influenza-like illness. And if you're looking on this slide, you'll see that in general, in healthy people, influenza lasts about a week, with the worst of the symptoms on the first or second day, and then all of them tailing off gradually. People who have underlying illnesses like asthma or lung disease are not more likely to get influenza, but if you do get influenza, obviously the state of the airways makes them more prone to irritation, and so in addition to getting the influenza infection itself, you go to the next slide, you get complications of influenza. And so the problem of influenza and other viral infections for people with asthma is the risk that they will trigger an exacerbation of asthma. The risk for all of us with influenza is that other complications will be triggered. So you can imagine if you've damaged the surface of your throat and the pneumococcus is growing on the surface, once there's damage there, it makes the pneumococcus more likely to invade. And so pneumococcal pneumonia and pneumonia due to group A strep are common bacterial infections that complicate influenza. It's those complications that make influenza dangerous. Just having influenza, you may miss a few days of work, other bad things may happen, but you'll get better. The complications are what make you much more severely ill. Okay, next slide. So, if you're a healthy adult, what's your risk of getting influenza? Influenza is the most common infectious disease. Okay, so in any given year, there's a little more than a 10% chance that you'll get infected with influenza and get sick. Most influenza just gives you a cold. You don't even know you had influenza, you just think you had a cold, a runny nose for a few days. About half of influenza is what we think of as influenza-like illness that I described before, with fever and feeling like you've been hit by a truck. And then if you go down the list, okay, about 1 in 50 people, so 1 in 4 or 5 people who get influenza, will be sick enough that they'll go to their doctor, who will diagnose a sinusitis or pneumonia, and they'll end up on antibiotics. We have until recently thought of antibiotics as very safe, but in fact, of course, antibiotics disrupt your microbiome. They give you vaginitis, they give you GI side effects, they select for antimicrobial resistance, they give you C. difficile infection. So if you get just living, there's about a 1 in 200,000 chance that you will get C. diff infection because of the antibiotics that you need to take your flu. So even though flu seems like it's a pretty minor disease, there is a risk of serious things happening. And you have about, as a perfectly healthy adult, you have about a 1 in 100,000 chance of needing to be hospitalized with flu, about a 1 in a million chance of going to the ICU, about a 1 in 3 million chance of death. Okay, so influenza is a really common disease. It has, for healthy adults, serious side effects, but they're really rare. Okay, don't happen commonly, but they do happen. Okay, now let's talk a little bit about other things you need to know about influenza when you're thinking about how to prevent it. The next slide shows you the 4 strains of human influenza that are currently causing infections around the world. 2 types of influenza A called H3N2 and H1N1. Think of them as families of influenza. And then 2 strains of influenza B called B Yamagata and B Victoria. The influenza B strains are related to each other. They started out as the same strain 30 years ago, but remember that influenza viruses change over time. Okay, influenza viruses are one of the very few infections where this happens. If you think in contrast to measles, if you get measles once or if you get 2 shots of the vaccine, the measles virus is stable and you are protected for your lifetime. You never have to worry about it. Influenza, however, causes repeated infections because it changes all the time. So on the far right side of this picture, you see the hemagglutinin molecule, which is the molecule that best stimulates our immune response. The bottom part of it is called stalk, and it sits in the membrane, and it's relatively inactive. The top part of it sticks out of the membrane, and it's what our immune systems respond to protect us from infection, but it changes all the time. So if I get infected with a strain this year, then next year that strain will have changed, and I'll be partly protected against it. I'll have some response to the immune system to it, but it'll be different enough that I won't be completely protected. And that's the reason why you keep getting influenza infections over your lifetime and why they're so frequent. It's also the reason why you need to get your flu vaccine every year, because when influenza changes, we change flu vaccines so that we try to keep up with influenza. One of the other things you need to know about influenza is how much influenza there is, and exactly when it comes varies from year to year. So on this graph, you see a slide of influenza activity in Canada when the different colored lines are activity in different years. So you can see the 2014-15 season in green, which had the highest number of cases, and the green line and the brown line and the purple line and the yellow line are all pretty much peaking at what you see on the bottom is around week 53 or week 1. So this is how we look at influenza season by weeks of the year. There are 52 weeks in the year, and then there's a few days in week 53, right, because there's not an exact number of weeks in a year. And this is when we usually think of as influenza season happening, right over the Christmas holidays, right? It's when most people are sick. But you can see in the blue line the 2015-16 season, where the peak of influenza was actually in week 10. So that's in actually at the end of February, the beginning of March. So influenza isn't continuous over the winter season in Canada. It's always about 10 to 16 weeks, but it can start as early as the middle of November, or it can start as late as the end of January, and we don't know when it's going to happen. We also don't know how much disease there's going to be. So you can see on this graph that in the green season, 2014-15 season, a lot of infections, but down at the lowest level is the purple season, where there were fewer than half as many infections. What's not on this graph is about once every 10 years, there's practically no influenza activity. Really good year, and people don't get ill. But we never know that ahead of time. So it's one of the big uncertainties about influenza is when it's going to come and how bad it's going to be. Okay, next slide. Picture of somebody sneezing, and you can see the spray of droplets that coming out of their airway, and that's how, of course, influenza gets transmitted. We think of influenza as being transmitted by sneezing and coughing mostly, and it's absolutely true that when you sneeze or cough, you project the particles from your pharynx further away. But of course, you don't sneeze or cough very often, but you breathe all the time. So there's actually more particles that escape from your pharynx when you're breathing than when you're sneezing and coughing. And things like talking also, of course, expel particles more and cause a greater risk of transmission. In fact, the biggest risk of transmission from particles is from people singing, particularly professional singing, because of course when you sing, you are projecting your voice so people can hear it at a distance, and that's a very effective way of spreading particles a long way away from you. Now, when you sneeze or breathe or cough, you, of course, if you look at the next slide, those particles come out. The person that you're exposing can breathe them in, but those particles also land on the face and the clothes and the hands of that person. And if that person then puts their hands up to the face, and all of us do that on a routine basis without thinking about it, then you can get influenza to your face. Or if you touch another person, if you're taking care of them, then you can transmit influenza to that person if you haven't washed your hands between the time of exposure and the time you touch the patient. So influenza is transmitted not only by breathing, sneezing, and coughing, but also, as you see in the next slide, by touching. Okay, switch over now. Streptococcus pneumonia. Streptococcus pneumonia is a bacteria, not a virus. That means it doesn't have to live in the cells of the host, can live on the surface, and most commonly, it lives in the back of your nose and down your throat. Its challenge is twofold. The first is it's not actually one bacteria, but a lot of different related bacteria. And what's different about them is shown in the electron micrograph you see on this slide. So you see the very dark bits are the cells, and that light space around them is what's called a capsule. It's secreted complex sugars from the bacteria that coat the outer surface and that protect the bacteria from all sorts of things like drying, but also from your immune system. So when our immune system responds to the pneumococcus, it's responding to that particular capsule of complex sugars, and that is specific to what's called the serotype of the Streptococcus pneumonia. So Streptococcus pneumonia, from your immune system's point of view, is not one bacteria, but many different bacteria, and that's the challenge of vaccinating against Streptococcus pneumonia. Quickly, pneumococcal disease is the second most common cause of vaccine-preventable death in the U.S. and Canada after influenza, which is the most common. Mostly, if you're an adult and you're going to get sick from the pneumococcus, you're going to get pneumonia, and you see a picture of a chest X-ray here with the bottom part of the right lung that you're looking at on the left. That is now white because of the inflammation, when lungs should be mostly black on X-rays because of its lungs are mostly air. So most commonly pneumonia, but also bloodstream infections and meningitis. So unlike influenza, pneumococcal infection is not that common, but if you do get a pneumococcal infection, much more likely to be severe. The next slide, again, you see that the reservoir for pneumococcus is our nose and throat, just like the reservoir is for influenza. And pneumococcus is transmitted from person to person in the same way that influenza is, by respiratory droplets from coughing, sneezing, talking, and then by contamination of the hands and touching. I'm sorry, something's gone wrong with this slide, I think. So strep pneumo infection, like influenza, is more common in the winter, and we believe that that's primarily due to the fact that in the winter you're more likely to get influenza and other respiratory viral infections that damage your mucosa and allow the pneumococcus to invade and cause disease. So these two infections are tightly tied to each other. Now, one of the differences between pneumococcus and influenza is shown on this slide. This is an infographic from the Centers for the Disease Control in the United States. And if you just press down one more, the box will come up. Anybody who has any underlying condition at all, whether it be HIV or diabetes or cancer or asthma, is at greater risk of pneumococcal infection. So the reason for a recommendation for vaccine for people with asthma is that we know that people with asthma are about 2.5 times more likely to develop serious pneumococcal infections than other people who don't have asthma. It's just a function of the degree of inflammation in the lungs and the fact that that makes it more likely that the pneumococcus can invade. Okay, so from this section, what's the same about influenza and pneumococcal disease is that they are common respiratory infections that can be severe, that they mostly occur during the winter season, and that they are both partially, not completely, but partially preventable. What's different about them from the perspective of asthma is that if you have asthma, you're not more likely to get influenza. Influenza is an equal opportunity infector. Everybody gets it. But if you do get influenza, it's more likely to be complicated. Pneumococcal infection, on the other hand, is actually more common in people with asthma because of the degree of inflammation in the lung. So now we're going to take a deep breath and switch topics to talk about protecting ourselves from influenza and pneumococcal disease. So on the next slide, there's 3 things that we know work to protect people from influenza and pneumococcal disease. I'm going to talk about vaccines for most of the rest of this talk, but just a point that washing your hands and what public health people call social distancing, which is just a fancy term for staying home when you're sick, both work to prevent illness. Social distancing obviously makes sense, but there is in fact evidence from influenza pandemics that if people stay home, they're less likely to infect their coworkers. Sadly, of course, if you stay home when you're sick, you're more likely to infect other people at home. So social distancing kind of cuts both ways. But when the next pandemic comes, there's enough evidence now that we will probably try to use some measures of keeping people apart from each other because that is likely to slow down the pandemic and make it easier for us to get vaccines to people and protect them. Hand hygiene also works. And hand hygiene works because your hands can get contaminated and then come and touch your face. And on the next slide, the fairly complicated slide, is one of the systematic reviews of hand hygiene and influenza transmission. And you can see at the top here that in the studies of hand hygiene alone, the risk ratio for people who used more hand hygiene was 0.86. So people who cleaned their hands regularly in these studies were 14% less likely to get influenza than people who were not cleaning their hands routinely. What does cleaning your hands routinely mean? Means in the community that when you go to bed at night, you should know that you have either washed your hands with soap and water or used alcohol hand rubs. It's got to be alcohol with 62% ethanol or isopropanol in it. The other chemicals do not work. But if you have done that 5 times, then you are about 15% less likely to get influenza, and your protection against other respiratory viruses, which seem to be more likely to be transmitted by contact, is even better. So overall, you get about a 25% reduction from respiratory virus infections. Imperfect, for sure, but still better than nothing. So staying home when you're sick, hand hygiene, and then vaccines. Now, what you need to know about pneumococcal vaccines now is a little more complicated than we hope it's going to be in about 5 or 6 years. And the reason for that is that at the moment we have 2 types of pneumococcal vaccines. One of them is called PPV23 and the other one is called PCV13. And the difference between them is you see both in the number and in whether the second letter is a P or a C. PPV is a polysaccharide vaccine. You remember I said that your immune system's reaction is to those complex sugars on the surface. Complex sugars are called polysaccharides. And when you give people a vaccine in which the antigen is polysaccharide, they respond with B cells, but you don't get a good T cell response. If you have a normal, healthy, and young immune system, then you respond well to polysaccharide vaccines, unless you're under 2, okay? So polysaccharide vaccines do not work well in very young children whose immune systems have not matured. They don't work well in older adults whose immune systems are getting tired. And they don't work well in immunocompromised people because of that reduction in the immune system. So because pneumococcal disease is so important in very young children, when people figured out that the polysaccharide vaccine did not work in children under the age of 2, they found a way of fooling children's immune systems into making antibodies to the polysaccharides. And the way you do that is by attaching a protein to the polysaccharide. It's called conjugation in chemical terms. And instead of your immune system being presented with just the polysaccharide, it's presented with the protein, and then your immune system makes B cells and T cells and responds much better. And so we now have this new group of vaccines that are called pneumococcal conjugate vaccines, that's C, that we use for small children and for older adults. And now we get to the number. Remember that there are many different serotypes of pneumococcal disease. The polysaccharide vaccine has 23 different serotypes in it. Conjugate vaccines we're still working on, and at the moment they only have 13. So for people with mature but not old immune systems, polysaccharide vaccine is better because it covers more serotypes. For children and the elderly, there's an advantage to the conjugate vaccine because you get a better response to it. There are new conjugate vaccines coming, so this is going to go away and get simpler, as I said, but it is going to be a little while. So the recommendation now for non-immunocompromised adults who are less than 65 years old, anyone with asthma who's aged 19 to 64 and is not immunocompromised, is 1 dose of the polysaccharide vaccine with 23 serotypes in it. For adults who are over 65 or who are immunocompromised, need a dose of the 13-valent vaccine, the conjugate vaccine, because you'll get a better immune response to it, and then you wait, and then you give the polysaccharide vaccine so you get the extra serotypes in the polysaccharide vaccine. Polysaccharide vaccine is not as good for the 13 serotypes that are in the conjugate vaccine, but it's still better than nothing for the other serotypes. So under 65, just the polysaccharide. Over 65, people should get both. The next slide is influenza vaccines. Influenza vaccines are, of course, much more complicated. It's really irritating. And not only that, but we've got a new nomenclature for them, the abbreviations for them. So you see that on this slide. So here's the vaccines that are technically available in Canada. Okay, so there's IIV3. So that stands for inactivated influenza vaccine with 3 strains in it, and the SD is standard dose. There's IIV4, which is the quadrivalent standard dose inactivated. There's LIIV, which is live attenuated. That's the one that comes in a nasal spray. And that one is not available in Canada this season and probably not next season. The UK has ordered very large amounts of vaccine. There's just not enough production capacity, and so we're not getting that vaccine this year. And then for older adults, there's an adjuvanted vaccine. So these only have 3 strains in them. They'll have 4 eventually, but they only have 3 strains for the moment. An adjuvanted vaccine, and then an IIV3 HD, which is high dose. High dose vaccine is just like standard dose vaccine, only instead of 15 micrograms of each of the antigens, it has 4 times as much, 60 times. So given all this plethora of influenza vaccines, can be really difficult and frustrating to sort your way through it sometimes. So what are the fundamental principles? The first fundamental principle is that any vaccine is better than no vaccine. People really worry about which vaccine to give, but not vaccinating people is even worse. So if you're stuck in the office and all you have is trivalent standard dose vaccine for somebody who's over 65, it's better for them to have that vaccine than to have no vaccine at all, and that's always really important to remember, particularly in a setting where we get what we get from the government, and sometimes there are real challenges with delivery of vaccines. A corollary to that is 2 vaccines are not cost efficient, so we shouldn't be giving people 2 vaccines because the benefit of the second vaccine, while non-zero, is pretty small. But if somebody gets the wrong vaccine and they want a vaccine that's better from them, on an individual basis, there is nothing wrong with giving them a second vaccine. The second principle to remember is that quadrivalent vaccine is more important for children. The 2 strains of influenza B are actually related to each other. They were the same about 30 years ago, and they've slowly been evolving apart. Every adult has had multiple influenza B infections and probably multiple vaccines, and so adults tend to have a good range of antibodies, a pretty good immune response against influenza B. You're just giving them a booster. And we adults get pretty good cross-protection against influenza B strains. Adding a 4th strain is good, but it doesn't add much. But children, particularly children under the age of 3 or 4, may never have had an influenza B infection. And so if you just give them 1 strain of influenza B, they make antibodies that are good for that strain, but they don't protect well against this other one that has just drifted apart a little bit. So because children are not getting boosted but maybe getting a primary vaccine, they get much more benefit from the additional strain in the vaccine. And that's why in Ontario for a couple of years we reserved quadrivalent vaccine for kids and gave trivalent vaccine to everyone else. In most places in Canada now, all of the standard dose vaccines are quadrivalent vaccine. It's not an issue anymore, but it's important to remember that it's more important for kids. And then finally, the vaccines for older adults, the adjuvanted vaccine and the high-dose vaccines are more effective, probably more effective in younger adults too, truthfully, but they're also more reactogenic. So because you get a better local immune system, you're more likely to get a sore arm and potentially some myalgias and feeling unwell for 24 hours. So look at this next slide against adjuvanted and high-dose vaccines. The high-dose vaccine we know from a randomized controlled trial is about 25% better than the regular vaccine for older adults. And at the price it is to the government and at the increased value, it's cost-effective. It's a good thing to be using for older adults. Adjuvanted vaccine, we have some evidence from immunogenicity and from observational studies that it's better than standard dose vaccine, but we don't have good quantitation of it. We don't have a randomized controlled trial. So that's why there's this difficulty with people comparing adjuvanted to high-dose vaccine. We know high-dose vaccine is better. We think adjuvanted vaccine is better, but we don't know with the same degree of confidence. They're both more reactogenic, okay? Definitely going to be more likely to get a sore arm with either one of these vaccines. But usually still goes away in 1 or 2 days. And the increase in systemic reactions of fever and malaise and myalgias is probably real. It's about 1 in 100 adults, so it's still uncommon and usually quite short, but does happen with these vaccines. And the third thing to know is that just because of the market, the high-dose vaccine is more expensive than the adjuvanted vaccine. So the reason that public health departments and provinces are struggling with which vaccine to supply is because we don't have direct comparisons between them. We have different levels of evidence, and they cost different amounts of money. So it's been really difficult for governments to know which to pick. From the perspective of providers, if you have available either adjuvanted or high-dose vaccine for your older adults, use it. If you don't, the regular vaccine is still a lot better than nothing. One of the common questions that people ask is shown on the next slide, which is, if you have an older adult, are you better off to give high-dose or adjuvanted vaccine that only has 3 strains in it, or the quadrivalent vaccine that has 4 strains in it? And if you look at this slide, and just bear with me on the numbers for a minute, you'll see clearly which one is better. So about 55% of influenza is A, H3N2. And we know that high dose is 20 to 25% better than standard dose against H3N2. The quadrivalent vaccine has a second strain of B. Overall, about 30% of influenza is B, and on average, half of that is the other strain. So the quadrivalent vaccine provides you better protection against 15% of strains instead of 55%. And in adults, it's only 15 to 20% better. So the quadrivalent gives you better protection against about 15% of influenza viruses and about 15% better protection. The high dose gives you 20 to 25% better protection against 55% of influenza. So even though the high dose is missing a strain, for older adults, high dose trivalent vaccine is better than quadrivalent vaccine, just hands down, no question. Okay, so now looking at this graph, okay, this is a report card that I put together from a variety of different sources of how well we're doing in getting vaccines into the arms of adults, okay? And what you see on this graph for a whole variety of vaccines is one C and a bunch of Fs. Truth is that we're just not doing well at providing vaccination for adults. And there are lots of system issues about that we're not going to talk about today. I want to spend a little bit of time talking at an individual level about why people don't get vaccinated. So moving on to the next slide, here's the number one reason people don't get vaccinated. They don't have a recommendation from their healthcare provider. Okay, the failing of all of us as healthcare providers that we don't do that we get so busy with other things in the office that we don't remember to do this. So let me show you some examples. Okay, here's a study of human papillomavirus uptake among women aged 19 to 26. Okay. Those who got a recommendation from their healthcare provider were many times more likely to be vaccinated, and the stronger the recommendation, the more likely they were to get vaccinated. Next slide shows you from our Canadian National Survey of Immunization, the difference in immunization rates for pneumonia shots, tetanus shots, and flu shots by whether or not somebody's healthcare provider had recommended them initially. Enormous difference, okay? So for influenza vaccine, 24% of people whose healthcare provider didn't recommend it, 79% of people whose healthcare provider did recommend it. Here's another American study from the CDC looking at the percentage of pregnant women who got their influenza vaccine. Okay, if the provider recommended it and offered it, 70% of them got vaccinated. If the provider recommended it but did not offer it, 46%. If there wasn't a provider recommendation at all, 16%. So we really need to appreciate how important it is as providers that we're making recommendations to people. And on the next slide, you'll see another important thing, that it's important not only that we recommend vaccines, but that we start on the presumption that people are going to get vaccinated. Now, you have to think about this a little bit because we've spent a lot of time in the last few years making patients partners in healthcare, wanting people to make their own decisions. And I was thinking about this the other day when I took my car in to get it fixed, and Carlos, the mechanic, called me and said, you know, you need new brake pads. Your brakes aren't working. And I realized as he said that I care about my car. I want to be part of decision-making about my car, but Carlos was telling me that there was a safety issue with my car that needed to be fixed. And I wasn't expecting him to call me and say, Allison, we need to have a conversation about the state of your brake pads, and you need to make a decision. I was expecting him to say, Allison, your brakes need to be fixed. And I think we need to appreciate that how we message to our patients is really important in delivering vaccines. So in this study, recent study in pediatrics looking at general recommendations, they recorded visits. And when the healthcare provider assumed that the parents were going to have their child vaccinated, they were 17 times more likely to be vaccinated. So, and that's about trust, right? When you go to your healthcare provider, you trust your healthcare provider to provide you with the best information, and frequently that's what you need to get vaccinated. It's really important that we do that. Okay. Next reason why people don't get vaccinated is because they don't believe they're at risk. And this, of course, is one of the most difficult things. We selectively forget when we get sick fairly frequently. And of course, if you're young and healthy, even if you get the flu, it's not likely that you're going to get serious complications from it. So it's really hard to know how to get the message to people who feel this way. Sometimes it's about saying, it's not just about you. It's about you transmitting the infection to other people, which of course we do. And we know that there's what's called herd immunity. So if I get vaccinated, I protect my elderly parents because I don't expose them. I protect my grandchildren because I don't expose them. I protect the patients I take care of. So Sometimes it's helpful to think about protecting other people. Sometimes it's one of the recommendations is, you're not very likely to win the lottery either, but you still buy lottery tickets, okay, because it makes you feel good and because there's a chance that it's going to happen. So there's always a chance that you're going to get flu. In fact, it's very common. And we really need to work at people understanding what those risks are and believing it. Okay. Next thing is about concern about side effects, right? And this comes in two categories. The first one is, every time I get the flu vaccine, I get sick. I'm tired of it. And the problem with that is shown on the next slide. So these data are from the largest randomized controlled trial of influenza vaccine in healthy adults ever. It's quite an old one. And you see here in people who got an injection, the number of people who reported side effects after the injection. 6% of them had a fever, 20% of them were abnormally tired, 6% of them had muscle aches, 14% had headaches. You look at that and you say, ooh, that's a lot of people being sick after the flu vaccine. Until you look at the next slide. And on the next slide, you'll recognize that those are the reported adverse events in people who got a placebo, a normal saline injection. So the problem with flu shots is we give them in October and November when a lot of people get sick from lots of other viruses. So when you get your flu shot, you might get sick after your flu shot. You get sick after your flu shot fairly regularly. The problem is it's not from the flu shot. And that's the message. I think healthcare providers are beginning to get that message that we give the flu shot when you're likely to get sick, and the sickness isn't from the flu shot. But it's still really hard to get people to understand that when they get sick 2 or 3 days after the flu shot, it's not from the flu shot itself. And then there are people who are concerned about more serious adverse events in the flu shot and who don't want to get the vaccine unless you can promise them that it's going to be perfectly safe. And of course, you can't promise people that anything is going to be perfectly safe. Life is not safe, right? People fall in the bathtub and get skull fractures and die. People have car accidents. People get hit by trucks riding their bicycles. Life is full of risks. The relevant question is not whether there are risks to getting vaccinated. The relevant question is the balance between the risks of getting vaccinated and the risks of being unprotected from influenza. And the problem with trying to do that calculation is as soon as you say vaccine, you know about the risks associated with vaccination. It's an active risk you're undertaking, whereas just being exposed to influenza doesn't feel like that much of a risk. But it's still a risk, okay? So this next slide, I'm not going to go into in detail, but it shows you the comparisons of the risks of getting vaccinated and the risks of not getting vaccinated, provided you don't live in a little HEPA-filtered bubble. And what you can see when you compare the numbers is that the serious risks from both being vaccinated and not being vaccinated are very low. But the risks of not being vaccinated are definitely higher than the risks of being vaccinated. So the messaging we need to get to people is not that vaccines are perfectly safe. Nothing in life is perfectly safe. Penicillin's not perfectly safe. All things in life have risks. But getting your flu shot, getting your pneumonia shot is lower risk than leaving yourself exposed to the disease. Okay, just a couple more to go. Lots of people say they don't think the vaccine works well enough, okay? How many times have somebody said to you, the pneumonia shot or the flu shot doesn't work well enough for me to be vaccinated. I'm going to wait till I have a better vaccine. So what do you get out of flu vaccine and pneumonia vaccine? Jim, you're going to have to tab through this. Influenza vaccine reduces your chances of hospitalization due to influenza by, depending on the year, by some number between 25 and 60%. The pneumonia vaccine reduces your chances of serious pneumococcal disease by 50%. So people look at that and they say, that's just not very good. And this is an amazing thing we have about double standards with vaccines, that we're prepared to completely throw out vaccines if they're not 100% effective. But let's think about some other things we do. So lots of people on statin medications now because we know they reduce your risk of heart attacks or of dying from heart disease, but the risk reduction is only 28%. Lots of people on blood pressure medications, excellent evidence that people should take blood pressure medications if they have high blood pressure. Those medications reduce your risk of heart attack by 20 to 25% and of stroke by 35 to 40%. Seat belts reduce your risk of serious injury in a car accident by 50%. Smoke alarms reduce your risk of death in house fires by 35%. So all of these are important interventions. They're mostly things that we do without even thinking about them, but they actually don't work as well as vaccines. So one of the things that we urgently need to do is get past this expectation that vaccines are only good if they're 100% effective. Our current pneumonia and flu vaccines are not actually very good on the scale of vaccines. What they are is a lot better than nothing, and that's what really important that we appreciate that. And then the last reason that people are worried about vaccines, and again, you're going to have to tab this, Jenna, is lack of trust. You know, that big pharma cannot be trusted. And it is true that most of our vaccines now are made by large pharmaceutical companies. The way capitalism works is those pharmaceutical companies are primarily oriented with making money for their shareholders. This is how life is. And it is absolutely true that some pharmaceutical companies have behaved very badly and misused the trust of patients and providers and the general public. But first of all, not most of them, okay? But secondly, remember that your vaccine recommendations do not come from pharmaceutical companies. Vaccine recommendations come from public health professionals. And public health professionals are people whose lives are dedicated to making your life and mine better. And so it's really that's why we have public health recommendations, to space them from pharmaceutical companies. It's why we worry so much about keeping our public health decision-making free of commercial interests, because, yes, we need to trust our decision-making about vaccines. But the truth is, if I can't trust public health professionals in life, there is no one else I can trust, and that's just not true. So it's really important to remember that our vaccine recommendations come from public health professionals who can definitely be trusted to make recommendations that are best for us. And I need to stop there because I don't think we have a lot of time left, but I would be very happy to take questions, and I put my email address up. You should also feel free to email me with any questions you have later. Thank you.
Excellent. Thank you very much, Dr. McGeer. It was very informative and detailed. We have a couple of minutes, so I'm going to run through some of the questions that have come up. From Evangeline, well over 10 years ago, I had the vaccine for pneumonia along with the flu vaccine, which I get every year. Last year, upon learning I had asthma, the nurse giving me the flu shot said I should have the pneumonia prevention shot every year, and I had one last year. I'm 66 years old, active, and pretty good health. Would you recommend a pneumonia shot every single year?
No. So the answer is no. You don't need a pneumonia shot every year. If you're over 65, you need to have had one shot each of the conjugate vaccine, so that's called Prevnar 13, and one shot of the polysaccharide vaccine, that's called Pneumovax. So when you go back this year to get your influenza vaccine, check to see which one you got last year and get the other one. But you don't need it every year. You just need to get one dose of it when you're over 65.
Great. And just to note as well, we have that information about those differing dose types on our website at asthma.ca. From AE, at what point in the season is efficacy of the vaccine determined based on the circulating strain?
So, yeah, this one of the things that we all want desperately is to know how well the vaccine is working early in the season. The problem is that you have to have enough cases to do that assessment. So at the moment, we have to be about halfway through the season before we get preliminary estimates of how well the vaccine's working. And that's again, like so many things about influenza vaccine, that's better than nothing, but it's not good. We really don't have a mechanism of predicting ahead of the season or of measuring early in the season how effective the vaccine is going to be. I think we are getting better with better understanding of influenza viruses, better ability to look at the shape of them and assess the importance of changes. So we are getting better at it, but we're still a long way. You just can't know how effective the vaccine is until later in the season currently.
Thank you. And then from Nora, can you please comment on the impact of pneumococcal disease on the functional status in older adults, such as a decrease in mobility or activities of daily living? And for older patients with asthma in particular, is there any evidence regarding the impact of pneumococcal disease on functional status?
So I don't think there's data specific to pneumococcal disease in patients with asthma, and a lot of the data we have is not even specific to pneumococcal disease. But there is no question that when older adults get ill from anything, particularly anything that means they have to be hospitalized, that there are significant losses that are really hard to recover from. You lose every day somebody spends in bed or in the hospital, you lose a measurable amount of muscle mass. And of course, it takes a lot of work to get that muscle mass back. We don't always appreciate how much of your bodily energy is required to fight off an infection. There is no question that anything that puts you in the hospital, anything that makes you ill enough to be bedridden for more than a day interferes with functional status, and recovering from it is increasingly difficult as you get older.
Great. And our last question here from Stacy. Does the flu vaccine efficacy wane? And if so, what is the best time to receive the vaccine?
The flu vaccine or pneumococcal vaccine?
The flu.
The flu vaccine, yeah. So yes, there is evidence that influenza vaccine depends on against which strain and in which year. And for young, healthy adults, probably not much evidence, but for older adults, you do get some waning. So what that means is you want to get vaccinated. You want to get vaccinated at least 2 weeks before the season can start. So second week of November at the latest. But you don't want to get vaccinated. You want to get vaccinated as close as possible to the end of the season, so probably not optimal before the beginning of October. It really hasn't, the evidence that we have of waning of the season hasn't made much of a difference to Canadian vaccination programs, because October and the beginning of November, or even the end of September, October and the beginning of November are the best time to get vaccinated. Those recommendations made a difference in the States, where influenza vaccines tend to come out in August, and people were starting to get vaccinated in August, and that's probably not ideal. But any time at the end of September, or October, or November is fine.
Great, thank you. So we are at the end of our time. Thank you so much, Dr. McGeer. I definitely appreciate you taking the time to give us this presentation. And thank you, everyone, for attending. If you have benefited from our webinar series and like to see similar programs, please consider making a donation at asthma.ca/donate. And if you have, at this point, if you have any further questions, please email us at info@asthma.ca, and we'll be happy to help and pass on any questions as well. And then just as a last reminder, if you're able to participate in our lung survey and vaccinations, we'd certainly appreciate it. Thank you very much, and have a great week.